Now, in this module, we are discussing biosafety. Now, biosafety is a matter of concern that is reflected in both WHO as well as the European Guide to Manufacturing Practices. In their Annexure 2, for example, for human biologicals, and in the subsequent annexure for veterinary biologicals, the regulators have drawn the manufacturer's attention to certain basic safety precautions that have to be taken while working with immunologicals. Now in India, we have a rich tradition of biologicals. We have over 100 years of vaccine production experience. We have the CRI, the Central Research Institute in Kasauli, founded in 1905, and Pasteur Institute in Kunur, founded in 1907. And both institutions have done themselves proud. The alumni from CRI can be seen almost in any biological facility in the country, and they are doing very important work and doing it successfully. But despite this rich tradition, the manner in which biosafety is viewed or practiced is rather casual, sadly. It's extremely worrisome, in fact, that people don't seem to think that biosafe practices are very, very important. I was taken to a lab by a young scientist and shown around. You walked up from the garden into a small airlock and then into her laboratory. It was just an ordinary laboratory with a window air conditioner. The windows were open so that fresh air could come into the lab. And there was a horizontal laminar airflow unit, a 4-foot wide horizontal laminar flow unit. So I looked around and was curious to know what work was being done in that laboratory. And the scientist explained to me that she was the one who was preparing the cultures with the virulent strain of anthrax for producing that dose that has to be injected into both the control animals as well as the test animals to check whether the anti-anthrax vaccine was really working. In an open laminar airflow unit, horizontal flow, in a laboratory with no controls whatsoever, no containment whatsoever. I was asked to help with the design of a P3 facility, and when I looked at the drawings and walked around the building and inquired about what are the other activities in that building, I found that there were ever so many laboratories carrying out work which required biosafety level 2 containment. When I asked the principal scientist as to why is it that no containment arrangements were being made in those laboratories, for example, animal molecular virology, they had fermenters, there could be aerosols and there could be hazards. But the director didn't seem to be impressed. He simply said that it's just level 2. Almost any laboratory in our country is level 2 anyway. Let's keep focused on discussing the requirements for the P3 facility. Forget the level 2 facilities. Recently, there was an engineer from Bangalore who was called to Delhi to attend to some instrument that had been supplied and installed there in a lab. On landing in Delhi and at the lab, the engineer found the lab closed. So he rang up the scientist concerned who had summoned him. And the scientist said, oh, we have a holiday today, but nevertheless, don't worry, I'll speak to someone. And he spoke to the attendant who was there to allow this engineer to go into the lab and complete his work. So the engineer went into the lab unattended. He completed his work and returned to Bangalore, only to show strong symptoms within a week, and a few days later passed away. This is the kind of gross negligence I have been encountering wherever I have traveled in our country. Now, workplace infection or workplace acquired infection is not restricted to laboratories. It also could emanate in production areas. Sadly, there's not much published data available about production space related acquired infection. But as far as the laboratory is concerned, some amount of information is certainly published and available from the laboratories in USA and a few other countries. But no information anywhere is either complete or even reliable. For example, if you are infected, you could have symptoms and you could have no symptoms. If you are infected beyond a point, you show the symptoms. But if it is subclinical, you remain asymptomatic and perhaps even undiagnosed. There is very scanty information about subclinical, asymptomatic, laboratory acquired or workplace acquired infections. Now, why do people take this so lightly? Is perhaps because of ignorance, is perhaps because of misconceptions. There are ever so many notions floating in the vaccinology industry. For example, I've been immunized, or that I'm working with an A virulent strain, or I am working with a dose level which is way below the infectious doses, or I'm working with a strain that is not known to infect humans, is not known to infect adults, and so on and so forth. Now, I've done a little bit of research to get together information that nails all these myths. So let's look at them one by one. First, let's look at the notions and then look at each notion and the information that is available about those notions. Common notions in biologicals. I am working with an A virulent strain. The organism I am working with does not cause disease in humans. The organism I am working with is attenuated and lacks the virulence to cause disease. The organism I am working with does not have any effect on adults. I am not directly involved with the work being carried out. I don't even go inside the laboratory. I am working with strains that induce the required immunoresponse but certainly do not cause disease. The concentration needed to induce disease is several orders of magnitude higher than that which may be ingested accidentally by me. So let's look at this A virulent strain, working with A virulent strains. 3 researchers in the same institute working with what they believed was the A virulent live vaccine strain of a particular organism, presented to their primary physician with respiratory symptoms. DNA test showed LVS contamination with a wild type. During investigation, the researchers admitted to use of no personal protection equipment whatsoever when counting colonies on an open bench. Please remember, vaccine strains that have undergone multiple in vivo passages should not be considered avirulent simply because they are vaccine strains. The next myth is that the organism does not cause disease in humans. There was a reported SVM crypto infection in the daughter of a veterinary student because of her soiled coveralls that she had left carelessly in the living room. Many agents not ordinarily associated with disease processes in humans are, however, opportunistic pathogens and may cause infection in the young, the aged, immunodeficient, or immunosuppressed individuals. The next myth is the organism is attenuated and lacks the virulence to cause disease. Now, It is well recognized that virus in attenuated vaccine for birds, for example, can, after 5 successive passages, regain full virulence. Now about the organism does not have any effect on adults. Now take pertussis, a human respiratory pathogen of worldwide distribution. It is a causative agent of whooping cough. The disease is typically a childhood illness. However, the agent has increasingly been associated with adult illness. Several outbreaks in healthcare workers have been reported in literature. 8 cases of infection with pertussis in adults have been documented at a large research institution. The individuals involved did not work directly with the organism but had access to common laboratory spaces where the organism was being manipulated. One case of secondary transmission to a family member was documented. A similar incident occurred at a large Midwestern university, resulting in 2 documented cases of laboratory acquired infection and 1 documented case of secondary transmission. Other laboratory acquired infections with pertussis have been reported, as well as adult to adult transmission in the workplace. Laboratory acquired infections resulting from the manipulation of clinical specimens or isolates have not been reported. The attack rate of this airborne infection is influenced by intimacy and frequency of exposure of susceptible individuals. Now about the feeling that I am not directly involved with the work being carried out in the laboratory. The transfer of an occupationally acquired infection to another person outside of the work environment has been reported, though uncommon. There have been 7 cases reported. There have been 2 cases at least of brucella through sexual transmission, 2 cases of salmonella, one of which was when a microbiologist prepared dinner for a family and resulted in 1 death. There's 1 case at least of leptospira through breast milk, and 2 cases of pertussis transmitted to family members. Please bear in mind, especially in the context of today's global travel and transportation, genetic mutations, transgenic mutations, and transspecies mutations are all eminently plausible and should never be discounted. Adolescents and adults with atypical or undiagnosed disease can serve as reservoirs of infection and transmit the organism to infants, children, aged, and immunocompromised people. Opportunistic pathogens and compromised hosts are all over the place. They are ubiquitous, and no precaution is too much in our endeavors to provide biosafe working environments. You have viruses that are variable. You have multiple ecological niches available for them, and further facilitated with global travel and transport. All this combines to give evolutionary opportunities for the viruses. Published reports of lab-acquired infections first appeared around the start of the 20th century and mainly referred to cases of typhoid as in 1885, brucella as in 1887, and tetanus as in 1893. The more famous reports of the 20th century are those from Mayer and Eddy of 1941 when they examined brucella infection. Between 1949 and 1978 by Sulkin and Pike, and their work was carried forward by Harding and Byers, and they looked at lab-acquired infections over the period 1979 to 1999. By 1978, 4 studies by Pike and Sulkin collectively identified 4,079 lab-acquired infections that resulted in 168 deaths occurring between 1930 and 1978. They collected information from as many as 5,000 laboratories, but sadly all of them were only from the United States. These studies found that the 10 most common causative agents of overt infections among workers were, and the list is given to you starting from brucella: The authors of that report acknowledged that the 4079 cases did not represent all the lab-acquired infections that occurred during this period, since many laboratories chose not to report overt cases or conduct surveillance programs to identify subclinical or asymptomatic infections. In addition, reports of lab-acquired infections seldom provided data sufficient to determine incidence rates, complicating quantitative assessments of risk. Similarly, there were no distinguishable accidents or exposure events identified in more than 80% of the lab-acquired infections reported before 1978. Studies did show, however, that in many cases, the infected person worked with a microbiological agent or was in the vicinity of another person handling an agent. This work was followed up by Harding and Byers. During the 20 years following the Pike Consulting publications, a worldwide literature search by Harding and Byers revealed 1,267 overt infections with 22 deaths. Sadly, out of those 22 deaths, 5 deaths were of fetuses, aborted as the consequence of a maternal lab-acquired infection. The authors also listed, out of the 1,267 infections, 1,074 were due to the top 10 pathogens were listed, starting from tuberculosis. The authors also identified an additional 663 cases that presented as subclinical infections, like Pike and Sulkin. Harding and Byers reported that only a small number of the lab-acquired infections involved a specific incident or exposure. The non-specific associations reported most often by these authors were working with a microbiological agent, or being in or around the laboratory, or being around infected animals. Now here are some of the more bizarre recent incidents of lab-acquired infection with serious consequences. There was a staff member in a clinical microbiology laboratory who accidentally subcultured melitensis on an open bench. This error and breach in containment resulted in 8 lab-acquired infections among 26 laboratory members, which shows an attack rate of 31%. In 1994 was the infamous Sabia virus infection at Yale University. Now, Sabia is an obscure but highly pathogenic arenavirus isolated in Brazil. There had already been 2 previous reported lab exposures, one of which proved fatal. There was this eminent physician, who's also a virologist, who had earlier worked on malaria and was now working at Yale Arbovirus Research Unit in a BSL-3 facility. There was a centrifuge accident. One of 6 250 ml centrifuge bottles leaked during centrifugation. Now the researcher diligently cleaned up the spill, but he did not wear any respiratory protection. More importantly, the researcher did not report the exposure and almost lost his life. But in 1997, the scientist at Emory University was not as lucky. There was monkey bee virus infection. Splashed in eye with body fluids, and the scientist was not wearing any eye protection. And the scientist did not report the incident until after onset of symptoms, severe fever and headache, and died as a result of human bee virus infection. The 2004 Culerensis infection at Boston University and 2006-07 Brucella coxiella infection at Texas A&M University were both very serious. While in both cases the scientists did not follow standard operating procedures, the Texas University incident was particularly sad because the supervisor had been immediately informed about the exposure and the accident, but he chose to ignore it till the symptoms showed up. The findings of Harding and Byers indicated that clinical and research laboratories accounted for 45% and 51% respectively of the total laboratory acquired infections reported. This is a marked difference from the laboratory acquired infections reported by Pike and Sulkin prior to 1979, which indicated that clinical and research laboratories accounted for 17% and 59% respectively. The relative increase of lab-acquired infections in clinical laboratories may be due in part to improved employee health surveillance programs that are able to detect subclinical infections, or perhaps to the use of inadequate containment procedures during the early stages of culture identification. Due to the lack of information on the actual numbers of infections and the population at risk, it is difficult to determine the true incidence of laboratory-acquired infections with any degree of certainty. Publication of the occurrence of lab-acquired infections provides an invaluable resource for the microbiological and biomedical community. Reports of lab-acquired infections can serve as lessons in the importance of maintaining safe conditions in biological research and production. Now, what are the lessons learned from all these laboratory-acquired infections? Most cases of laboratory-acquired infection are not associated with a documented accident. In fact, more than 80% have no direct exposure documented. The most effective methods to prevent laboratory research-associated infections are risk assessment, establishment of appropriate SOPs, education, training, use of appropriate precautions, including personal protection equipment, and practice and timely reporting. Supervisors, principal scientists, and investigators must understand and recognize the signs and symptoms of disease, including their incubation period. Institutional biosafety councils and institutional biosafety committees can play a vital role for all these perspectives. I'd like to end this session with a quote from the Health Canada Laboratory Biosafety Guidelines. The attitudes and actions of those who work in the laboratory determine their own safety and that of their colleagues and of the community. Laboratory equipment and design can contribute to safety only if they are used properly by people who are genuinely concerned and knowledgeable about safety.